A 40-year female was admitted with history of sudden severe headache followed by altered sensorium since 2 days. On examination, GCS was E2, V2, M4 and bilateral pupils were mid-dilated and sluggishly reacting. Plain CT head done after admission showed a hyperdense lesion along posterior falx cerebri. This is the plain CT head showing the hyperdense lesion marked with the arrow. So after plain CT head, we planned for DSA brain to look for any vascular pathology if present. DSA brain showed Borden type 2 and Cognard type 2 A plus B dural arteriovenous fistula. This is the DSA brain of left ECA, AP and lateral view showing the dural AV fistula with arterial feeders marked with red arrow, retrograde venous flow marked with black arrow and cortical venous reflux marked with blue arrow. This is the image of the DSA of the left ECA showing the high flow dural AV fistula with multiple arterial feeders from the left occipital and left middle meningeal artery marked with red arrows and cortical venous reflux marked with black arrow. Also, we could see that there is obstruction in the venous sinus proximally, which may be due to thrombus, due to which there is reversal of venous flow. This is the image showing the Cognard classification system of dural AV fistula. Cognard type 1 dural AV fistulas drains into venous sinus with normal antegrade venous flow. Cognard type 2 A dural AV fistulas drains into venous sinus with retrograde venous flow. Cognard type 2 V dural AV fistulas drains into venous sinus with normal antegrade flow along with cortical venous reflux. Cognard type 2 A plus B dural AV fistulas drains into venous sinus with retrograde venous flow associated with cortical venous reflux. Cognard type 3 dural AV fistulas drains directly into cortical veins with no venous ectasia. Cognard type 4 dural AV fistulas drains directly into cortical veins with associated venous ectasia. And Cognard type 5 dural AV fistulas drains into spinal perimedullary venous system. These were the treatment options available with us. A. Endovascular approach. It involves embolization of the fistulous connection by using either embolic agents such as N-butyl cyanoacrylate, Onyx, fill, precipitating hydrophobic injectable liquid or detachable microcoils. It includes trans-arterial embolization, transvenous embolization, combined trans-arterial and transvenous approach. B. Surgical disconnection of the venous sinus. C. Stereotactic radiosurgery. We prefer to choose trans-arterial embolization of the high-flow dural AV fistulas, Cognard type 2 A plus B using liquid embolic agent Onyx 34, protected with detachable microcoils creating a pressure cooker effect. The trans-arterial route was chosen as the dural AV fistulas has multiple arterial feeders and it would be difficult to embolize it with the transvenous route. These were the hardwares required for the procedure. A 8 French femoral sheath, a 6 French envoy guiding catheter, a 6.3 French distal access catheter DAC 070, one Apollo Onyx Delivery microcatheter, an Echelon 10 microcatheter, liquid embolic agent Onyx 34, and target 360 standard coils. After explaining the procedure and taking well-informed consent of the patient's husband, patient was shifted to the DSA suite. The patient was placed supine on the table and GA was given, and right inguinal region was prepared for femoral access. Then using the Seldinger technique, right femoral artery was punctured and accessed using a 8 French femoral sheath. Then a 6 French 100 cm envoy guide catheter was advanced to the aortic arch and sequential angiogram of the right ICA, right ECA, left ICA and left ECA were taken. This is the DSA of the right ICA, AP and lateral view showing the normal arterial filling with minimal venous sinus drainage. This is the DSA of left ICA, AP and lateral view showing normal arterial filling with reduced venous drainage. This is the DSA of the left ECA, AP and lateral view showing the high flow dural AV fistula with multiple arterial feeders marked with red arrows from left occipital and left middle meningeal artery along with the retrograde flow into the sinus marked with thin black arrow and cortical venous reflux marked with blue arrow. Then we cannulated the left occipital artery with 6.3 French distal access catheter 070. A selective angiography of left ECA was done with magnified view and a roadmap was taken. A dimethyl sulfoxide compatible Apollo Onyx Delivery microcatheter was then advanced and parked distally in the feeder branch of the left occipital artery marked with blue arrow. DAC 070 is marked with black arrow. A 150 cm Echelon 10 microcatheter was then taken and advanced over a 200 cm synchro microguide wire and the tip of the microcatheter was placed in the same feeder branch of the left occipital artery but proximal to the tip of the Apollo Onyx Delivery microcatheter. The Echelon 10 microcatheter was chosen as it is DMSO compatible and can be used both for deploying the microcoils as well as injecting the Onyx. And then we started deploying the coils through Echelon 10 microcatheter to make a pressure cooker effect during injection of Onyx. The Onyx which will be injected will be delivered only distally without reflux into the proximal feeder vessels. This is the first coil deployed, marked with the arrow. This is the second coil deployed, marked with the arrow. After deploying the coils, we delivered liquid embolic agent into the feeder vessels and venous sinuses through the Apollo Onyx Delivery microcatheter. This is the AP and lateral view of the DSA showing injection of Onyx. This is the DSA showing the Onyx cast in the feeder vessels and the fistulous connection. The immediate post-embolization DSA of the left ECA showed complete obliteration of the occipital artery feeders with retrograde flow into the sinuses through the middle meningeal arteries. The DSA of the left ECA taken 15 minutes after Onyx embolization showed complete obliteration of the occipital artery feeder branches with no flow into the sinus. The DSA of right ICA, AP and lateral post-embolization showed normal arterial filling with normal re-establishment of antegrade flow into the superior sagittal sinus, which was not present before the embolization procedure. This is the video of the patient on post-operative day 4 with a GCS of E4, V5, M6 and the improved neurological status. This is the video of the patient after 1 month with improvement in the neurological status. These are the references.